in the 21st century than David. In fact, you could say he spent his whole life preparing for this talk. Okay? His specialty when he was a resident, studying to be a physician, was general preventive medicine. He taught and practiced public health and community medicine at the med school at the University of Washington. He served a decade as the CEO and chairman of the Kaiser Foundation Health Plan. And now, as a teacher and a writer and a thought leader, he's highly sought after as an advisor by businesses, new and old, including SomaLogic. Today, he's going to help us wrap our minds around an alternative model for primary care that's rooted in the family and in the community. David, we're looking forward to it.
Thank you. It is wonderful to be back, and I need to start with a confession. What? I'm not going to tell the towel joke. That's your joke. Right. Ketchup bottle? No. I had my speech written 3 weeks ago and was looking forward to spending the last 3 weeks going over it and refining it. And I had the good fortune of spending a day at a program at Kaiser Permanente, a day-long program on community benefit. And it rekindled some things that had been dormant for a long time in my own thinking about the question of primary health care and health care in the 21st century. There were several takeaways from that meeting that I've tried to incorporate into my talk, but the reason I bring this up is that the thinking that I want to share with you today is really just, it's ideas in progress because they're relatively new. They've been stimulated by that day at Kaiser Permanente. Let me give you a couple of the key themes that came out of that discussion. The first was that Kaiser spends 3.7% of its gross revenues on something called community benefit. At a company that is now roughly $60 billion a year, that means as a foundation, they are investing somewhere around $2 billion a year in improving the health of the community. A year ago, they decided that that wasn't enough. And they decided that for a couple of reasons. They said, we want to be at a position that we can offer Medicaid-eligible patients and members an affordable health care solution and still make the margins that we need to be able to reinvest in facilities and technologies. Getting down to a cost structure that allows you to make money at Medicaid reimbursement rates is non-trivial. What they decided is they can't do it by making medical care much better. They have to do it by changing patterns of demand for medical care. They have to get in front of it and behind it, around it. And so now their entire strategy can be captured this way. They believe that every cent they spend has to be tested for the impact they're having on the health of the communities they serve, not their members only, but the communities they serve and the communities of the United States. So the metrics they're now initiating to determine whether or not they're doing what they need to do are metrics of population health as well as the sub-metrics dealing with what happens inside the medical care system. It's an amazing change. And it turned my head around in terms of the way I was thinking about what I wanted to say today. So as I said, what I'll share with you today are ideas that are kind of in the making. They go way back to periods when I was, as was mentioned, when I was in the Peace Corps or when I was in University of Washington, when I was the health officer for Multnomah County in Portland, Oregon, and working in the jails. They go to a lot of different parts of my own experiences, and I'm still honestly trying to knit them together. So I'd like, during the question period, and as you think about this, to think about this as sort of thinking in progress or work in progress, and I'd love to get feedback from you at the, during the Q&A period. Let me start with a story. One day I walked into the detox facility in Multnomah County, Portland, Oregon, the Hooper Detox Center, which is where all the drunks get taken by the police at night. It's a rubberized holding cell that will hold up to 30 or 40 people, and it's divided men and women. And the next morning, after guys have kind of begun to sober up, they either released out onto the street or they choose voluntarily to come up to the second floor for a 3 to 5 day detox. And the holding cell gets hosed out. All the guys get a shower, deliced, et cetera, like that before they're sent out. Happens every day, 7 days a week. So I was having sick call up in the detox facility. I walked in to the clinic, or to my exam room, and sitting on the exam table was this short, huge Lummi Indian from the Lummi Indian Reservation outside of Tacoma. And his luck would have it, his name was Tiny, of course. He was about 300 pounds. And he had a cold, so I started examining him, talking to him, and he was really a delightful guy. And I took off his shirt. He had a chest cold or something like that, and I was listening to his chest, and all down the front of his chest were a pattern of scars. And he was a keloider. They looked like the snakes going up and down his chest. I said, God, Tiny, what happened to you? And he said, well, let me tell you. He said, this happened a couple of years ago. It was in late November in Portland, Oregon, and that means rain, cold, gloom. And I had just spent my last dollar getting absolutely tanked at a local bar on the east side of the Willamette River. He had been there for 2 months with all of his earnings from working on a salmon boat, and every year he came to Portland with his pockets full of money. He hooked up with a prostitute. He lived in a dingy little dive down in Lower Burnside, and every night he got drunk. This last night, he was walking back across the river, or across the bridges, and if you've been to Portland, you know it's a city of bridges. He's walking across this bridge at about 1 o'clock in the morning, just hammered. I was walking across the bridge, and this bunch of punks in a gang jumped me. It's called jackrolling. They jackrolled me. And they wanted to take my money. And they were beating me up, and they were trying to find my money, and I kept saying, I don't got any money, I don't have any money. So they stripped me, and they threw me off the bridge into the Willamette River. I was probably 40 or 50 feet down. And he says, I was sober by the time I hit the water, as you might imagine. He said, and I know how to swim. And so he floated down the river to something called the Broadway Bridge in Portland. Now, the Broadway Bridge has the car lane up above and a railroad track underneath it. Maybe the steel bridge. I don't know. Which one is it? Steel bridge, I think. Anyway, the lower one is the railroad track. And he grabbed onto the pylon, and he pulled himself up onto the railroad tracks, and that's when he just cut the complete hell out of himself. He's absolutely stark naked. It's 1 o'clock in the morning, and he starts walking across the railroad track out onto the green belt right along the Willamette River, right into the spotlight by the Portland policemen who were in the patrol car seeing him coming. Now, this is Tiny telling me this story, so I apologize in advance. The policeman got on the bullhorn and said, hey, Tiny, what are you doing? And Tiny goes, I'm streaking, you dumb sons of bitches. He had blood just coming down his chest. He was taken to jail, stitched up a little bit. I tell the story of Tiny because it captures what I want to talk about today. Tiny is our problem in the United States. Let me tell you how. Behind me is a picture of a huge traffic jam. In the interest of time, I didn't show you what is reported as the world's largest traffic jam, which took place in Beijing and was 65 miles long. But this gives you an idea of a traffic jam. Now let me ask you, how would you deal with a traffic jam? What do we need to think about in order to solve a problem like recurrent traffic jams? If many of you travel internationally, I've had the distinct pleasure in my life of sitting in traffic jams in most of the major cities of the world. So how do we solve that problem? Okay. Talk about it. Talk a little more about some of the things you need to think about. How would you think about doing this? Alternative ways to travel, right? Alternative transportation, less cars, driver education, fewer people. Well, smarter roads. Here's one of the ways that you wouldn't solve the problem. This is a repair shop. Now, you got to have it, right? You got to have a repair shop to take care of the cars that have fallen apart because they've been in these traffic jams or been used on inappropriate roads or crashed into other cars. But that's a repair shop. Healthcare is the world's biggest human traffic jam. And it cannot be fixed by medical care. Medical care, our hospitals, our doctors, our clinics, are repair shops. They're taking care of bodies that have fallen apart or are falling apart or have been damaged. Now let's look at this traffic jam and see if we can figure out a little more about why we have to come at it with very different lenses. I think you can see that. These are some of the numbers from the World Health Organization, the United States, CDC, et cetera. Just take a look at some of these numbers. Obesity, 17% of the children in the United States are obese. 34% of adults in the U.S. are obese. Colorado does pretty well, by the way. And at 1.7 billion estimated, 1.7 billion adults in the world are obese. Now just think about what obesity carries with it in terms of pathology. Look at smoking. 21% of the world's population over 15 years of age smokes, mostly in the poor and emerging economies. Look at diabetes or hypertension. A third of the adult population in the United States is estimated to have hypertension, and only 50% are controlled. And interestingly enough, about 1 billion adults worldwide are calculated or estimated to have hypertension. And most are not diagnosed, let alone treated. Now, there's overlap, obviously. Many of these people will have more than one of these problems. Look at the numbers for diabetes. 79 million adults are pre-diabetic in the United States. And it's already the number one cost in healthcare costs in the United States, just taking care of the people we know about. There's 79 million more that we haven't even started to touch. And depression is another major issue. This is probably underreported. This is the United States. That's worldwide. The estimates from the WHO, it's probably very much understated. But these huge numbers are very similar to the kinds of things you saw in that photo of a traffic jam. They're just big numbers, lots of people, and lots of more illnesses that you could account for. Huge numbers of people who are either not treated or poorly treated, poorly controlled, undiagnosed, who represent this traffic jam, this human traffic jam. The trouble is, it's not just about those big macro numbers. And this gets back to tiny. Look at some of these numbers. The percent of individuals who didn't complete high school varies from 9% among white non-Hispanics to 18.8% among Hispanics. Education and educational level are one of the most powerful predictors of adult health status. Hypertension is far more common amongst non-Hispanic blacks, as among whites. It's about 42 to 28%. And then look at the levels of control are lowest amongst Mexican Hispanics, and particularly Mexican Hispanic women. Here's another really interesting piece of data that came out about 8 weeks ago, a new study looking at a new method for calculating the rate of preventable deaths due to medical error in hospitals. The range is about from, his numbers were from somewhere between 250,000 deaths per year to 450, and most of the people who reviewed the numbers felt that the upper number was more likely to be correct because of substantial underreporting. It is the third leading cause of death in the United States. Medical care, which is supposed to help, is the third leading cause of death in the United States. Now, he stated that it's the number one preventable cause of death. Excuse me, I just jumped one. That was not what I was supposed to be talking about. Okay, back. Look at the difference in hospitalization rates. We will talk a little bit about preventable deaths from preventable injuries, I should say, in the hospitals. But look at the difference in hospitalization rates. Interestingly, it's inverse. The higher your socioeconomic status, the less frequently you'll be in the hospital. And look at the rates by about these, in the difference between whites and African Americans. It's about a 2x difference. And look at the costs if you were to eliminate those disparities, about 1 million hospitalizations a year. That's just in the United States. This is a wonderful statement from a biostatistician from WashU. She was speaking at a Harvard School of Public Health event, and she made the comment that your zip code is a far stronger predictor of your health status and your future health status than your genetic code. Kaiser Permanente did, and when I saw it was at this meeting I mentioned earlier, Kaiser had done a couple of studies. First of all, fascinating piece of work, 40% of the members of Kaiser Permanente are below the poverty line. 40% of the population, the membership of Kaiser Permanente is below the poverty line. And if you look at Alameda County, which is the home county of Kaiser Permanente in Oakland, California, you will, and you plot the rates of hospitalization, the rates of hypertension, the rates of diabetes, and the average years of preventable deaths that vary across these different zip codes, you will see what looks like a mosaic of colors from extremely high levels of those illnesses in certain zip codes, and next to it, very comfortable levels of prevalence. And they really vary by a combination of education, income levels, whether or not you're employed, things of that nature. And it varies as closely down as zip codes. And this is a quote from Donald Barr's book. It was published a couple of years ago. The lower one is situated on the social hierarchy. The lower one's probability of staying in good health and lower one's life expectancy. There are huge disparities, and we're talking about anywhere from 5 to as many as 10 years in predicted life expectancy from a child who makes it through the first year, depending on where you're born, what kinds of socioeconomic circumstances you live in, what kinds of education you have access to. And this is another quote from one of my heroes, Michael Marmot, who has done a huge amount of work on disparities in healthcare. He did the first really interesting work called status syndrome, in which he studied the rate of illness correlated with your status in the civil service of Whitehall in England. Universal health insurance and health coverage through the National Health Service. But as you might expect, what he found is the lower you are on the civil service hierarchy, the greater the prevalence of illness. And it's not a break point where everybody was healthy until you hit a certain level of poverty or a certain level in the civil service ranks. It actually is a gradient. And he has studied that in a number of countries, published a major study for the World Health Organization. He's now the president of the World Medical Association. And what he's found every place he has done the work is that there's a social gradient, or a gradient of health and health outcomes, health status, that is directly linked to your position in the social hierarchy. It's fascinating. The people with the greatest health in terms of predictive years of fulfilled life, lack of hospitalization, lack of chronic illnesses, and so are the people at the top. We're the people who are getting paid all the huge money for all the stresses we're living under, right? Because we've got all this responsibility, right? We're running these big organizations. The sad truth is, it's not that stressful, especially not when you compare it to what it's like to be on the bottom of the totem pole. Now, there are lots of ways to look at this. Again, another quote from Michael Marmot. And then my statement. Our U.S. healthcare traffic jam is getting worse as a result of the rising burden of chronic and often preventable illnesses, driven in turn by growing differences in life conditions, education, and opportunities for personal choice among our increasingly diverse populations. Now, what's fascinating about this is that it sounds like a political polemic until you look at the data. And there are very interesting ways to look at these data. One of them has to do with what happens when you intervene in some of these differentials in terms of income or education or childcare or employment, and you actually see improvements in health status when that occurs. Been numerous experiments in Europe, numerous experiments in Asia in this regard. Many people argue, well, the reason people are sick is because they start out with a bad protoplasm, and that's also the reason they're at the bottom of the totem pole. But the data don't support that. The data support the fact that when you intervene and provide these opportunities or narrow the differences between the lowest and the highest in the hierarchy, you actually see vast improvements in health status. And the most notable ways to look at that is to look at the differences in health status from low to high in places where there is a substantial emphasis on creating educational opportunities in equal ways, social infrastructure and safety net, income transfer programs, things of that nature. And they typically fall in the Nordic countries, as you would expect. But there, the differentials from low to high are very, very limited, very low in terms of adverse health differences in adverse health outcomes. There's still there's that gradient, but they seem to be narrowing it through these kinds of interventions. So it suggests that circumstances, education, income, employment, empowerment is what Amartya Sen, the Nobel Prize economist, calls it. Your sense of being able to fulfill your opportunities and fulfill your dreams have a lot to do with your health. So what? That's all really good. We know that in the United States we're not going to do much about it. People don't believe in all that crap, and if they do, they don't fund it, or they can't decide. What's ironic in the United States, of course, is that we've been trying to solve the traffic jam in our country with bigger and more expensive and more powerful body shops. Build more hospitals, train more doctors, get more specialized. Very interesting book called The American Healthcare Paradox, which came out a year ago, in which the authors stated inadequate attention to and investment in services that address the broader determinants of health is the unnamed culprit behind why the United States spends so much on healthcare but continues to lag so far behind in health status. We rank typically between 17th and 20th in most major indices of health compared to the other developed countries in the United States, or in the world. And we spend at least double on acute medical care. Now let's look at this a little bit further. We pay top dollar for hospitals, physicians, medications, diagnostic testing, and skimp in the broad areas that are central to health, such as housing, clean water, safe food, education, and other social services. This is from a 2002 study that Mike McGinnis, who's Chief Operating Officer now of the Academy of Medicine, the old Institute of Medicine. Mike did this study, and this was just calculating how much was spent on acute medical care and public health. He didn't even include social services, but 95% of the dollars spent in the United States go for acute medical care, taking care of broken bodies. 5% goes to public health, and it's declining. This doesn't even include the disparity in social services. Let me make one more comment about social services. In the 20 or 30 countries of the OECD and the rapidly developing economies, the United States stands alone in the ratio of expenditures for acute medical care versus social support systems. 2 of every $3 we spend is for acute medical care when you add in the social services. Remember when I talked about Mike McGinnis, he was just looking at public health. In contrast, most of the other countries, with the exception of Mexico, spend about 2 of every $3 or slightly less on the social safety network, the support systems that deal with the primary causes of ill health. And they enjoy a much better standard of health and health care, and health outcomes than we do in the United States. Well, let's talk a little bit about what we know about the determinants of health. But first, this idea of spending on acute medical care is dumb. It's just misguided for 2 reasons. First of all, we cannot invest enough money in the United States to build sufficient manpower, health manpower, and hospital and clinic capacity to deal for all the demands for broken bodies. Moreover, the costs of care are going to increase like this as long as we focus on that acute care medical spend and trying to get people their access to medical care paid for through national health insurance or however we're doing, ACA, for example. It's an important step. You've got to have medical care, but it's chasing your tail. We can't do it. We already have a gap, depending on the numbers you read, anywhere between 20,000 and 100,000 in primary care physicians. I've said that before in this group. Huge deficit in physicians. And yet around the globe, not just in the United States, countries like China, countries like India, countries like Saudi Arabia are spending like mad to build lots more hospitals. Makes no sense whatsoever. And the second bullet is the reason. Medical care isn't the right solution for this traffic jam. It's like building more body shops. Let's look at the determinants of health. Now, this comes from work that Mike McGinnis does, it's the same paper that I quoted earlier. But this is the model that Kaiser Permanente is using to drive its strategy for its interventions. When you talk about the determinants of health status in a population or even at an individual level, we think this is it's pretty rough, but what proportion is explained by each of these things? So genetics, we believe, around 30% of the health outcomes that we're witnessing. Behaviors, 40%. Environment, maybe 5%. Socioeconomic circumstances, in general terms, about 15%. And medical care contributes about 10% to the outcomes that we have in terms of health status. So we're investing 95% of our money over there. Now, a couple of things about this. First of all, behavior suggests that it's all about individuals and individual responsibility. Tell that to Tiny. Tell that to Tiny as he goes back to his reservation and drops himself into a subculture of fast foods and alcohol, a subculture of no educational achievement or very low educational achievement, and say, hey, dude, take care of your hypertension and don't fall off bridges. Stay away from violence. Kaiser, again, to quote them, is now saying that chronic diseases are contagious because they occur in populations and they recur and are made worse by the conditions into which patients who may be treated have to return to try and take care of their illnesses. So as we look at these determinants of health, there are two levels at which we can intervene. And I'd like to talk about the second, the individual level. There are many policy issues, there are many programmatic issues, political solutions to these that countries have tried around the world with a wide variation of success. I want to talk about the individual areas because I think that's often overlooked in these debates. I think there are a number of solutions that we have available to help individuals deal with some of these determinants of health, and they will work only if we do the policy work as well. So I'm going to walk you through these very quickly, but let's just imagine a few things. Let's imagine an FDA-approved silicon chip the size of a grain of sand, powered by a biodegradable battery, activated in your gut, sending information about the pill, the dose, when it was taken, which batch, to a Band-Aid on the stomach that's also capturing physiologic information about heart rate, respiratory rate, etc. And from the Band-Aid, it's sent to your mobile phone and on to the caregivers. Now, let's say that clinical trials show a dramatic improvement, in fact, a completely unprecedented improvement in control of hypertension and control of type 2 diabetes using this closed-loop kind of adherence program, coupled with education and coupled with the patient making the decision about who is the caregiver or the caregivers to get this information to help him or her stay in control or in compliance with the medications that have been prescribed. That company is called Proteus Digital Health. And at its last fundraise, the post-money valuation was $1.3 billion. They're now conducting a major experiment in the UK to use this tool to help people with chronic illness manage their illnesses more effectively. Larry, you'll recognize this one immediately. Now imagine that you can capture circulating proteins on a chip, do a lot of them at one time, very inexpensively, and you can capture the samples in a mall or in a home or wherever you need to, and diagnose yes, no, whether or not through that screening tool, yes, no, whether the illness is present. No doctor, no judgment. It's binomial almost, yes or no. That's what SomaLogic is trying to test. Or imagine you could get personalized support tailored to your particular style of personality and behavior change that changed over time, delivered on a handheld device to help you change critical behaviors in managing your chronic illness. That's a new code that I'm actually working on with a young entrepreneur in Silicon Valley for type 2 diabetes. Now here's another one. Imagine that you are diagnosed with a chronic illness, or you're obese, or you're hypertensive, and you walk out of a safety net clinic, and every day or every few hours you get a text message from the clinic that reminds you to take your medication, reminds you about the foods you should be eating, reminds you to get out and take a little walk, reminds you when your next appointment is. And it's in your language. You know who the highest users of text messaging are in the United States are Hispanics, turns out. This is a company that's organized as a not-for-profit foundation, headquartered in Palo Alto. It now has 600,000 patients that it serves, growing to 1.5 million patients by the end of next year, serving 38 states, and roughly 140 safety net providers, and it's pennies per day. The impact on compliance, on no-shows in clinics, the impact on the lives of individuals, their ability to keep to the regimens that are very difficult to stay with, the reminders and help that they get, have shown dramatic improvements in outcomes for hypertension and type 2 diabetes control for pennies a day using handheld devices. Now, what we've learned from these kinds of things, these technologies marrying with science, are a series of knots. Things you don't do with this stuff, and things that we learn about the interventions that matter for the determinants of health. Let me run through them, and I hope it really ticks you off. First of all, it isn't medical care. Doctors don't do this very well, and they don't do it very well not because they aren't motivated or trained or even good at it. They just can't reach very many people. 20 people a day, 25 people a day. And given the amount of time you have in your daily clinics to see each patient, maybe 10 minutes a day with a patient, 10 minutes per patient, maybe 15. And if you see a diabetic, I've said this before, if you see a diabetic maybe 4 times a year, that's a grand total of 40 minutes, maybe an hour. That's not a very good place to be doing these sorts of things that help people change and manage their behaviors in conjunction with other social changes that we're not going to talk about today. The second thing about these solutions that we've learned is that they cannot be institution-based. They can't force people to come somewhere in order to get them, like we do to clinics and like we do to hospitals. People want access to this kind of information to help them with their daily lives. They need it 24/7, 365. They need it when they need it. They don't want to have to get in the car and come to a clinic or make an appointment. It is not expert or professionally based. A lot of this grows out of the science that is, as I said, binomial. Care Message, the company I mentioned with the text message, is really good at designing communications for different ethnic groups and different language groups. Not time-based. What I mean by that is it's not limited to the hours that the clinic or the hospital or the ER is open. It's not expensive to buy or use. It isn't cumbersome. And it is not variable and inconsistent the way a labor-based solution is. Let me put it in the positive. In order for these things to work for the kinds of traffic jams that we're dealing with, they have to be scalable, they have to be low cost, they have to be repeatable, and they have to be reliable. And that means you can't use people to do them. At least not primarily. You can't solve these problems with labor. So let's just finally talk about how to organize our thinking about this. You can't boil the ocean here. It's very helpful to think about the 9 domains in which patients or communities or families need help and are asking for help. And all of these fall into those categories I described as knots. You can solve these problems without having to go into the medical care system. Triage. Do I need to go to the doctor or not? Do I need to come to the emergency room or not? Do I need to use the medical care system or not? If I do, where do I go? If I get a bunch of information from different players, how do I integrate it? How do I understand it? How do I take care of myself for my chronic illness so that I don't have to go to the medical care system? Remember, 98% of what you do for yourself with a chronic, or what you need to do with a chronic illness is take care of yourself and create the environment around you that allows you to stay as healthy as you can with that illness. The medicine, the diagnosis is part of the treatment, but the real issue is this. Rehab is another area. What do I do after I have knee surgery or after I have hip surgery? Why do I have to go into PT? Is there something I can do in my home? Is there something I can do in conjunction with videos, for example? Been doing a lot of that and with telemedicine, for example, in patients who are at too far a distance to be able to come into a center. Screening is what Larry is talking about with SomaLogic. Another area that we need to divorce from the medical care delivery system and move to where we can reach the consumers so they can be screened, whether or not they're generic consumers or they've already been selected to some extent because of increasing risk or increased risk. Most wellness interventions, and there we're talking about stress-free environments, better nutrition, better exercise, things of that nature, are also amenable to those kinds of non-medical care-based solutions. And finally, if you think about hospice and you look at the most effective hospice care systems, they are not run by doctors, although docs have a role in helping with the prescription, with the prescribing, and pain relief. But generally, they're run by algorithm. They're run by very highly trained nurses and other support people, and they're brilliant. Now, if you look this a little bit further, and we think about where the intervention opportunities are and the way to sort of organize our approach to designing care systems to deal with these determinants of health, clearly you have those three levels of intervention, the individual, the provider, and what I'm talking about there is not the physician provider or the clinical provider. I'm talking about the organization that is delivering the service. Let me give you an example of what I mean. Grocery Ships is a company in Southern California located in West LA, close to Watts, and it is designed to help women who are, black women who are obese, suffering often from diabetes, suffering from hypertension, and have family members who are the same and have no access to healthy foods. They're in food deserts. It's designed to help them understand how to shop better, how to cook better, and how to exercise. And it's had a dramatic impact as these little cells of groups of mothers, really, come together and teach each other with help from staff. They're supported through a number of technologies. And what we've seen with that program is an impact on the health and nutritional status of their families in addition to their own illnesses. That's a provider. Grocery Ships is a provider. And then we're talking about using technology primarily, and the algorithm really needs to be how can we minimize the labor in each of our interventions, because labor is expensive, it's variable, and it isn't very scalable. Now, these changes that are underway, this is a wonderful statement from the fourth Industrial Revolution. It said, the changes are so profound that from the perspective of human history, there's never been a time of greater promise or potential peril. So luckily, he doesn't believe in hyperbole. I'm sure there are many other times in history that people would have said the same thing. But there really are a number of perils here. The first is misusing technology. The second is continuing our love affair with the medical care system, which needs to be as good as it can be. I'm not denying that it needs to be good. But we have really tipped the balance in favor of funding medical care systems, especially in the United States, to the detriment of the health of the population, and particularly to the detriment of the populations that lie below the very top. Because each increment you drop down in the socioeconomic status, your health status worsens and is more amenable to the kinds of social networking or the social interventions and social service interventions, income interventions, et cetera, that have proven to be so effective. And lastly, I want to end with this quote. And I'm going to read it because I thought it was beautiful. This comes from a speech by Bobby Kennedy at the University of Kansas in 1968. Gross national product counts air pollution and cigarette advertising and ambulances to clear our highways of carnage. It counts special locks for our doors and jails for the people who break them. It counts the destruction of the redwood and the loss of our natural wonder in chaotic sprawl. Yet the gross national product does not allow for the health of our children, the quality of their education, or the joy of their play. It does not include the beauty of our poetry or the strength of our marriages, the intelligence of our public debate, or the integrity of our public officials. It measures neither our wit nor our courage, neither our wisdom nor our learning, neither our compassion nor our devotion to our country. It measures everything, in short, except that which makes life worthwhile. End quote. I'd be glad to take your questions. Why don't you do it?
Okay.
Yeah.
Questions? Yes, sir.
Hi, David. Thank you very much for the talk. About the first part of your talk, as you may recall, once upon a time I was a police homicide reporter in Chicago, lived in Africa, spent about 10 years doing work on development, worked for the CBO overseeing social programs. And most recently, I was having a discussion with one of the largest affordable housing programs in the country about the problems in Jackson, Mississippi. And the one term I think, as you were talking, brought to mind was safety. At the end of the day, we do not have safety. Safety is a problem. Safety is a number of different variables.
Absolutely.
But what happens is healthcare problems emanate from a lack of safety. And you're absolutely right. We all worry about our employees or this, that, and the other thing. There is nothing like worrying about where the next dime is going to come from, what's going to happen to my kids, whether I'm going to be in the street, and more importantly, what's going to happen to my family as a result of that.
Yeah.
That is stressful. And so one of the things that I've come to realize is the importance of community. And we can talk about technology, but in a sense, technology divorces us from community because it's remote. And in the affordable house, well, community and stigma, that's the other thing. And what was very interesting in the affordable housing program, this woman who was actually ran Mount Bayou for 15 years in Mississippi. What was most telling was she talked about people graduating out of the affordable housing situation. And I said to myself, well, wait a second. You're creating a system there which is very resident-driven, community-based, and now you're saying, if you get a job, you leave. And now you're out there where there is no community,
Yep.
there is no support.
Yep.
And I think we really need to start rethinking and moving towards integrated communities. One of the good things that was done in Britain, although it's been lost sometime, was the integration of public housing within the community.
Yep.
We weren't all segregated.
Right.
So I was wondering if you could just talk about
Sure.
those issues as well in relation to what Kaiser
You remember the determinants of health. I indicated two interventions. One was public policy and sort of political action, organized action at the community level, at the state level, et cetera. I wasn't able to talk about it. We didn't have time today. But you're absolutely right, Steve. That housing is critical. Public safety is critical. The impact on health of chronic instability in employment, chronic instability, lack of safety in the streets. I can't go out and walk. I'm afraid I'm going to get mugged. All those sorts of things that keeps, especially the elderly, bound at home. But all of it is built around this issue of community. And frankly, although there have been some very interesting efforts in the United States to try and create these more stable communities in these more difficult areas, I think Europe has been much ahead of us in that. In some places, I was just reading this morning, I think it was in Sweden, one of the towns in Sweden, for example, just passed a law, which is very controversial. I think it was in the New York Times this morning, a 6-hour work week, or 6-hour workday, mandating that. And the reason was to get people cut down on the cost of childcare, cut down on the amount of time people are spending going to and from work, cutting down on being exhausted at the end of an 8 or 10 or 12-hour shift. They're literally, if you read the WHO Commission on Health Inequity, there are just hundreds and hundreds of opportunities to influence that at the programmatic level. I emphasize the individual, because typically we go to the programmatic questions first. And I wanted to make sure we didn't lose the opportunities to, A, divorce the medical care system from trying to be the resolution of what happens with individuals, but to also encourage the medical care system to participate in the solutions at the community level.
Right, and the other thing, and I did this in England, is there is no difference between social and healthcare. That's one of the things that we've come to do. They're flip sides of the same coin.
Yep.
And one of the things that was done in England recently, and I really, when I was involved, really pushed to think of it this way, was the social and healthcare budgets have now been brought together, so it's one budget. And in fact, in some respects, I would argue that social, health, and also retirement are really all part of this.
The income security issue, you bet.
Yeah.
We're going to get some other questions.
Larry, did you want to come in? This will probably be the last intervention, I think. Go ahead.
I found everything you said right and wonderful, not wonderful, but right. And the part that shocked me the most was when you said one sentence. You said that 40% of Kaiser's members are below the poverty line. Wasn't everybody in this room shocked by that? I was.
Well, Kaiser has set out to enroll 1 million Medicaid-eligible people through the ACA and is almost there. So they've added 950,000 new members to their 11 million.
To get to 11 million, right?
They have other state programs, and there are a number, remember, there are a lot of workers who aren't working, who aren't earning at the federal poverty line yet. They may be part-time workers, they may be low-wage earners who are statistically below the poverty line, who still have access to health care benefits and may have access to Kaiser that way. I think all of us were shocked when we heard that number. Yeah.
I'm very reluctant to cut this short, but if we're going to get out of here anywhere near the time on the schedule, I'm afraid we're going to have to do that. David, thank you so much.